Okay, Rachel, you are up. Thank you.
Hey everyone, my name is Rachael Willeford. I am the Senior Coverage and Reimbursement Specialist here at ASCO's Care Delivery, and we're here today to go over the 2025 coding updates for oncology. And we are so glad you can join us. Thank y'all, everyone, for being here with us today. Coding changes can affect practice reimbursement, and being prepared for those changes can save a practice both time and money. As a reminder, the American Medical Association updates the CPT codes annually with a fall release, with those codes going into effect on January 1st. The ICD-10 CM codes are maintained by the National Center of Health Statistics, a part of the CDC, and that is done on an annual basis with an effective date of October 1st. Finally, HCPCS codes are released by CMS on a quarterly basis. ASCO does distribute resources to coincide with each of the regularly issued coding updates. First, we're going to go over the 2025 changes and updates for the CPT codes. CPT codes are proposed, reviewed, and approved. That's done 3 times a year at the CPT editorial panel meeting that is held by the American Medical Association. Approved codes are then added to the CPT code set, with the year being dependent on the CPT schedule. Specialty societies like ASCO advocate for their members and their specialty by participating in this process. The largest group of changes for CPT this year are 17 new codes for telemedicine, like the office and outpatient evaluation and management visits. A medically appropriate history and/or exam is required, and the level of service of these visits is determined by either medical decision making or time. As you can see here, we have 8 new codes for synchronous audio video codes. They are divided into new patient and established patient codes, being divided into straightforward, low, moderate, and high. So they do have time thresholds of 15, 30, 45, and 60 minutes for new patient, and 10, 20, 30, and 40 for established. There are also 8 new codes for synchronous audio video. So we have audio video, and then we also have audio only. Those are also divided into the medical decision making levels, and you will also find the time to be the same as the audio video. These are also divided by new and established patients. Just a note that currently, according to the proposed rule for Medicare, Medicare is not proposing to cover these codes. That they are saying that there are other established codes to use, like the office and outpatient E&M codes, that could be used in lieu of these telemedicine codes. Currently, though, if a physician in 2024, if a physician is performing a telephone E&M visit, the CPT codes 99441 through 99443 are available to report these services dependent on time. However, in 2025, these codes will be deleted, as the telehealth evaluation and management codes 98008 through 98015 will be available to report E&M visits, including those with audio only. So no more telephone visits in CPT code set. Another thing is currently there is the G2012, G2252, and 99441 through 443 that are reported for virtual check-ins. So G2012, the description states that it is a brief communication of a technology-based service provided by a physician or qualified healthcare professional. In 2025, There is a new CPT code that adopts that same language. It's 98016. And Medicare has decided to adopt that CPT code as well. So what 98016 is, it's brief conversations related to medical discussions that are lasting 5 to 10 minutes. These conversations must be patient initiated, and they may be only provided to established patients. Basically, the discussion between the patient and the provider is going to determine whether a more extensive visit is warranted. This virtual check-in cannot be reported if it's related to an evaluation and management visit that occurs within the 7 days prior to the service, or if it results in an E&M visit up to 24 hours later or at the next available appointment. If it does result in an E&M on that same date of service, the time that is spent for that check-in can be included in the time of the E&M visit that results. Although this slide does show that audio visits codes 99441 through 443 have previously been reported for this service, in 2025, if the services end up with an evaluation and management visit, that's if those services include if it's interactive, it's in real time or audio, and it meets the time and medical decision-making requirements, synchronous audio only E&M visits may apply, but you have to meet those time requirements too. Of note, this does not replace interprofessional consultations or consultations of any kind. This is just a brief check-in. So for the a comparison, what telehealth is different between CPT and CMS in 2025. So for the CPT guidelines, there's no special modifiers anymore. They have specific CPT codes to report the telemedicine visits. The place of service would be where the patient is located, where the service is being rendered, and what insurance is what insurance is dictating, and it applies to any specialty. CMS, on the other hand, according to the proposed rule, they're going to bundle the telephone visits, since the CPT codes that are for telephone visits 99441 through 443, those are going to be deleted. And since CMS is proposing to reimburse CPT 98016, they're going to start bundling those telephone visits. You would report E&M telehealth with the appropriate either office visit or another appropriate code as indicated by CMS. CMS requires modifiers, and they're also proposing to only cover specific places of service and specialties. Those flexibilities that you could provide this anywhere, and those might be ending. We would get to that in a final rule probably conversation. We'll give you some information on that at the end of the webinar. Again, payer policy does vary because, as we have seen after the pandemic, policy can vary quite widely. So it's definitely a good idea to refer to individual payer policy for telehealth coverage and requirements. We have some actual new oncology codes. So in 2019, there were Category III codes that were created to report for the harvesting, preparation, and administration processes for the delivery of chimeric antigen receptor T-cell therapy, which is commonly referred to as CAR T therapy. In 2023, ASCO, along with other stakeholder specialty societies, they worked together to have these Category III codes converted to the Category I codes you see here. These codes apply to autologous CAR T cell therapy and the work that is done to harvest lymphocytes, which are then prepared for transportation to a manufacturing or cell processing facility. And once those CAR T cells are then received back from the manufacturer, The modified cells are prepared and then administered to the patient. Incidental hydration and medications that are related to the administration of CAR T therapy are included and they are not reported separately. If they are unrelated to the administration of CAR T, then you can report those separately. The modified cell product may be reported with the applicable Q code, in addition to that administration code 38228. The work done by the manufacturer, though, is not included in these codes. This is what is done for physician work and what's done at either a facility or office. Medicare does currently include the payment for the collection and preparation with the payment of the biological. Now, we are waiting to see what the final rule says on these codes, whether there's any bundling, because they did request commenting on these codes. Finally, Category III CPT codes. So these are temporary codes that typically, when they are put into the code set, typically last for 5 years. They are for emerging technology, just to facilitate data collection usually. When they are in the code set, there's no RVUs that are assigned to them. It's merely for data collection and trying to get some data so they can potentially become Category I codes. There is a new Category III code that is oncology related. It is 0901T. That is for the placement of a bone marrow sampling port. It's so that they don't have to, it's so they don't have to tap the bone marrow more than once. Like, it's just to facilitate it. It does include imaging guidance. So that should be interesting to watch for the next couple of years. Next, we'll go on to diagnosis coding. Our ICD-10-CM that went into effect on October 1st. So ICD-10, or the International Classification of Disease, these ICD-10-CM codes are copyrighted by the World Health Organization. ICD is copyrighted by World Health. In the US, the ICD-10-CM codes, which we refer to as diagnoses codes, are developed and maintained by the CDC's National Center for Health Statistics. These codes are used to report diagnoses associated with services, procedures, and supplies that are provided in all healthcare settings. The 2025 update to the ICD-10-CM code set has a large number of additions that affect hematologic malignancy, along with some codes pertaining to signs and symptoms, and some factors influencing health status that are oncology related or oncology adjacent. Before we get into the nitty-gritty, let's go over some general diagnosis coding conventions. When you see the word "and" in a descriptor, it should be read as "and" or. If you see "with" or "in," that means that something is associated with or due to, and indicates a causal relationship between two conditions. If a symptom is routinely associated with a disease or condition, it's not to be reported in addition to the disease, since it is considered part of the disease or condition. And then pretty much the golden rule for diagnosis coding is code to the highest level of specificity as possible. That's just, and then just a quick review of some terms that you may see in ICD-10-CM coding. So excludes one means that the two codes cannot be reported together. And excludes two means that the one condition is not part of the other condition that's being referred to, but the patients instead may have both conditions at the same time. use additional code means that an additional code should be reported if it's applicable to provide kind of a complete picture of the diagnosis that's being discussed or being referred to. And then code also means that more than one code may be required to fully describe a condition. So the first of the changes. So remission status was the name of the game here this year. So remission status has been added to quite a few of the hematologic malignancies, over 60 of them to be specific. The first is lymphomas. It is the codes are being added in which there is an A as the fifth character to indicate whether that condition is in remission. You see it from C81.0A all the way to C85.9A. Anything from Hodgkin lymphoma, all the grades of follicular lymphoma, your B cells and mantle cells, Burkitt lymphoma, all the way to the unspecified types of non-Hodgkin lymphoma. They're really trying to get down to whether or not this is in remission or whether or not this is not. This is just being still being treated. There are also some codes that have both now a remission and not in remission status. That is either revised or added. So the fifth character, like before, is going to indicate the remission status, but instead of an A, it's going to be either a 0 or a 1. So either, for example, if the conditions are in remission, like our example of blastic NK cell lymphoma, it's going to have a 1 in the fifth character place. If it's not in remission, there's going to be a 0 in that fifth character. So it's going to be very important to note that there's not a code if the remission status is not specified. What does that mean? That means it's going to be imperative that remission status be documented for a code to be selected. So now let's look at a couple of some more of these other than just this example. What other codes are affected by this? The other specified types of T and NK cell lymphoma. So your extranodal nasal types, your hepatosplenic T cells, your blastic. If these are not to be confused with the mature T and NK cell lymphomas, which have that A as the character that indicates a remission status. These are going to fall into those that have both a remission and non-remission status. There are additional other condition families that belong to the malignant immunoproliferative diseases and certain other B cell lymphomas that have been affected by the remission, non-remission revisions. Again, either a 0 or a 1 is going to be in the fifth character place. That's going to indicate whether that's in remission or not in remission. Conditions like Waldenstrom macroglobulinemia, your MALT lymphomas, those that your immunoproliferatives that are just not specified. Again, not an A where there's just a remission or the condition, but there's either a remission or not in remission. So in addition to the remission status changes, there's also a new hematologic malignancy code. So C83.390 is indicated for primary central nervous system lymphoma. Now, this code is not going to include Burkitt's, lymphoblastic, peripheral T cell, or other lymphomas that are in the primary central nervous system. Those would be indicated by the applicable codes for extranodal and solid organ sites. This is just going to be central nervous system lymphoma. For signs and symptoms, not really a sign or symptom, but it's a syndrome. Carcinoid syndrome occurs when a carcinoid or neuroendocrine tumor releases chemicals into the bloodstream, and it can cause multiple symptoms ranging from flushing, wheezing, diarrhea, even to cardiac involvement. So these codes are going to be reported with the malignant endocrine tumors that are indicated with C7A or C7B. Though when you see the malignant endocrine tumor codes, they also have a use additional notation that these syndromes may need to be reported if they are if it's a condition experienced by the patient. Toxicity. So we have seen previously toxicity codes for anti-neoplastic and immunosuppressive drugs. That's going to be a T45.1AX and whatever the intent is. Now we have T45 I'm sorry, it's going to, the anti-neoplastic and immunosuppressive is T45.1X with the sixth character. This is T45.A. So this is poisoning or adverse effects of or underdosing of checkpoint inhibitors and immunostimulant drugs. What this means is that it's going to be very important to know what type of drug a patient is experiencing a toxicity to, an adverse effect of. So it's going to be important to be documented and to know what drug classes these drugs are falling into. The seventh character, that is seventh character, is going to indicate the intent and effect, whether it's accidental or whether or not it's an adverse effect with the 5 or underdosing. That is also going to need to be known as well. Z codes typically can be reporting additional information to show maybe a complexity, condition of a patient's story. However, our code set is also correlated to statistics. Currently, we already have Z codes that have estrogen receptor related Z codes for our breast cancer and other cancers that are related to these hormones. Now we have those for our PR hormonal indicators, receptors, and also our HER2 receptors. It is going to be Z17.21 and 22, and then Z17.31 and 32. Noted that HER2 is not just related to breast cancer, but also bladder, pancreatic, ovarian, and stomach cancers. And what else do we see? Oh, we see a combined receptor status. So now that we have the ER, the PR, and now we have the HER2, when it is the combination is documented, we can use the combined receptor status. And note that we now have a way to indicate that a breast cancer is triple negative with the Z17.421, which would be hormone receptor negative and HER2 negative as well. The last updates to our Z codes, 2 more social determinants of health codes. In our other presentations that ASCO has done, we've seen some problems related to housing and economic circumstance. And what we see is we have a lot of codes maybe for housing, but we don't have a lot of codes for some of the others. Well, now we have 2 more codes to indicate problems with a patient's health coverage. So we have the insufficient health insurance coverage, Z59.71, and we have insufficient welfare support, which is Z59.72. We also have that immune checkpoint inhibitor popping back up. as a personal history of medical treatment that is indicated with Z92.26. Finally, we have just a few revisions. We have a new excludes 2 on the DO5, which is the carcinoma in situ of the breast. That means this excludes 2 means that the malignant neoplasm of the breast may occur as in addition to the cancer in situ. So both of them could potentially be reported. We see that sometimes where there may be some in situ in addition to pockets of that with breast cancer. The cytokine release syndrome, there's a note in there to use the additional code to identify an adverse effect of immune checkpoint inhibitors. And then your T45.1, which is the toxicity of anti-neoplastic and immunosuppressive drugs. There's an excludes 1, which means you cannot report both the T45.1 and the T45.A, which is the anti-neoplastic and the immune checkpoint inhibitors. Moving on to HCPCS updates. So the HCPCS manual, you can find that and purchase the publication annually. However, the actual code set itself, there are updates that are released quarterly by the Center of Medicare and Medicaid Services. And those updates go into effect on the quarter that is specified. So we're going to cover additions in that code set that are related to oncology that will be that you will see or have seen over the course of the year, as well as what we are expecting in January of 2025. So first are 4 codes for the treatment of multiple myeloma. The first being Elrexfio. So this drug was originally assigned to C9165, which has now been replaced with J1323. Both Elrexfio and Talvey that are on here are for adult patients having relapsed or refractory multiple myeloma and have received at least 4 prior lines of therapy. So Talvey also had a C code, C9163, and is now with a J3055. The Effexta, which is now assigned to J2277, is used in patients with multiple myeloma in combination with a drug filgrastim in order to mobilize hematopoietic stem cells for transplant. And then lastly, we have the melphalan, which is melphalan hydrochloride. It's for palliative treatment of patients with multiple myeloma when oral therapy is not an appropriate treatment. So this is J9249. This is not to be confused with the melphalan on the next slide in the Heptazo kit. So these are all anti-neoplastic or immunotherapies. The first being J3263 for Loqtorzi. This is used for nasopharyngeal carcinoma, either as a single agent or in combination with cisplatin and gemcitabine. The second you will see was originally C9170 and is now J9026. That is Imdeltra. This drug received accelerated approval from the FDA for use in patients with extensive stage small cell lung cancer. Excuse me. The next one also had a C code C9169. That has now been replaced with J9028. That's Anktiva. That's indicated for adults who have BCG unresponsive, non-muscle invasive bladder cancer. Noted that this is for intravesical chemotherapy use only. So not a typical chemotherapy administration in the office. Again, next we mentioned the Heptazo in the last slide. Heptazo is reported with the J9248. This Heptazo comes in a kit used for percutaneous hepatic perfusion, where the drug melphalan is delivered intra-arterially to the liver for patients with uveal melanoma with unresectable liver mets. The second to last would be Tevimbra, which is assigned to J9329. This is a PD-1 antibody used for unresectable or metastatic esophageal squamous cell carcinoma. And then the last one is a trastuzumab biosimilar, Hercesi, which this is a biosimilar to the reference drug Herceptin. It's reported with Q5146. So this is going to be a monoclonal antibody against HER2 receptors used in breast and certain gastric and gastroesophageal junction cancers. On the next slide, we have 4 supportive care drugs that were added this year. The first being Lumosite. So this is a imaging drug, so reported with an A code, A9615. You may see Lumosite used as an optical imaging agent used in intraoperative detection during lumpectomy surgery for patients with breast cancer. That's pretty interesting to me. The second is an antiemetic, J1434 Focanase. The third one is a GCSF, so it's a granulocyte colony stimulating factor, like Neulasta, Udenyca, those, it's in the same kind of family. It's J9361. It's not a biosimilar for them, but it does stimulate growth of neutrophils. So its indication is to decrease incidence of infection in adult patients with non-myeloid malignancies receiving myelosuppressive anti-cancer drugs associated with clinically significant incidence of febrile neutropenia, much like the other drugs, but again, not a biosimilar. What is a biosimilar, however, is the Q5136, which is a denosumab biosimilar. Jubbonti would be a biosimilar for Prolia formulation, and Wyost would be for the Xgeva formulation. Again, denosumab, the Prolia and Xgeva, they're the same drug. It's both Jubbonti and Wyost are the same code. You use the same code, Q5136, and Prolia and Xgeva use the same code, right? What indicates which drug it is the dosage. So the dosage for Prolia and Jubbonti would be for your osteoporosis and your certain osteoporosis indications, and as well as the prevention of osteopenia and osteoporosis. Wyost and Xgeva is going to be indicated for your bone mets, I believe hypercalcemia, and your giant tumor. Actually, I think Wyost may only be your giant tumor cell and your bone mets. Revisions that we're seeing back in April, these are from April. Q2055, which is for the CAR T cell drug Abecma. or the biological Abecma is prior to April 1st, the description indicated that this was up to 460 million CAR T cells. Now they're allowing up to 510. The next revision is J9250. So they did discontinue the methotrexate sodium in the 5 milligram billing unit. Now J9260 is not a new drug or a new HCPCS code. This was in existence before 2024. But now this is the only code that you can use to report methotrexate, and that is with a 50 milligram billing unit. We do have 2 discontinued codes. Ranitidine, J2780. It's been taken off the market, so they decided to discontinue it. And then J9371 for vincristine sulfate liposome was also discontinued. Vincristine sulfate, there's a code out there still for that. They're just discontinuing the vincristine sulfate liposome. Now a group of, I won't say codes, it's not codes, but there's a lot of this phrase in the HCPCS. It's not therapeutically equivalent. So a couple of years ago, CMS created these codes for single source drugs and biologicals. And they conducted this review of products which are not therapeutically equivalent to a reference drug. And it's indicated in the FDA Orange Book. And since they're not therapeutically equivalent, they aren't within the same billing and payment code as the other drug and biological. So what CMS did is they established a revised codes to separately identify these drugs that may have been previously reported as a not otherwise classified. And they're still doing this with all subsequent code applications. So what does that mean? That means whenever there's drug application transfers and there's changes to manufacturers, there may be revisions required for descriptions, which we saw this year. So there was a new code that was established this year, J2468, for palinositron hydrochloride from Avixa. Fast forward to the end of this year, and we're revising this code because the drug application was transferred to Pospria. So J2468 is now being revised. J9271 for docetaxel is also being revised because the manufacturer changed. And now we have a new pemetrexed by Avixia, which was approved and assigned to J9292. In here, I have included the reference code so you can see which drugs are the actual reference. Effective at the end of this year, CMS revised J9033 to take Trienda and the HCl out of the description for bendamustine. They are changing it to just hydrochloride, and they're going to discontinue the other 2 codes for the, or 2 other codes for the manufacturers, Apotex and Baxter. Then we have a lot of changes with cyclophosphamide. First, they discontinued J9070 and they created a new code, J9075, for cyclophosphamide that's not otherwise specified. And then they revised J9072 to indicate that this is no longer Avixa and it's Dr. Reddy's instead. And then they also created 3 new codes for 3 different manufacturers for cyclophosphamide. Lastly, they have discontinued J9258, which is for paclitaxel protein-bound particles manufactured by Teva. So what CMS said is they believe this to be a multi-source drug now and should be billed with J9264 effective January 1st. Lots of changes. Going to our resources, ASCO actually has quite a few resources. First, I will say we didn't touch on a lot of the final rule changes, just a few bits. Gina Hoxie, who is our Director of Payment and Access of Regulatory Affairs in ASCO's Policy and Advocacy, is actually going to be presenting in a webinar later in November 21st to be exact, on the physician fee schedule final rule updates. I promise I'll be there. You should be too. And then ASCO always has resources available on our coding and reimbursement page. These are corresponding to the information provided in this presentation. They are written resources that you can look to. You can also print out, that are oncology specific. So you don't have to go through the whole entire CPT book to see what is applying to oncology. You don't have to go through the other ones. We have annual CPT updates, ICD-10 updates, and quarterly HCPCS updates. Where can you find this? You can find this if you go to asco.org and you select practice and patients and drop down to the coding and reimbursement page under the billing, coding, and reporting tab. You can find this there, along with other resources like ASCO's tip of the month, our updates. We have E&M guides, and we also have practice administration guides. Some of our topics for that are like advanced care planning and care management, social determinants of health. And we also have a resource that goes into a comparison of care management and the patient navigation codes that have been a hot topic this year. While you are on this page, make sure you stop by our Medicare resources page as well. You can find resources on NCCI edits, Medicare contractor information, skilled nursing facility consolidated billing, amongst more. In addition to these resources, we also have some resources from CMS that we used for this. CMS's HCPCS quarterly updates, along with Medicare learning articles. ICD-10 has a landing page with the National Center of Health Statistics, and ASTCT has a CAR-T coding and billing guide. They are the cellular therapy specialty organization, so we kind of defer to them on cellular therapy matters or education. In addition, I would like to mention that ASCO offers membership for the entire cancer team, including practice administrators. And membership offers benefits like networking with other oncology professionals, advocacy tools out there, and educational opportunities like the one you've participated in today. If you have any questions about the information we've covered here, those can be sent to ASCO staff at practice@asco.org if you would like, or if there's any questions at the time, I will be glad to take those questions at this time.
I do not see any questions currently in the chat or the Q&A right now. So again, as a reminder, I'll put this in the chat. You can email us at practice@asco.org. And a member of ASCO staff will be happy to assist you. Thank you very much for your time today, Rachel, and thank you to the attendees. Please get in contact with us if you have any questions, and be sure to visit our coding and reimbursement site. Thank you and have a great afternoon.